Rickets is a common pediatric problem which often encompasses largely conditions associated with nutrition deficiency of vitamin D and calcium, but also may represent the rare situations of disorders of either the renal tubules, phosphate metabolism, or vitamin D production or action, which are non-responsive to vitamin D therapy. Identification of refractory rickets at the right time is essential so as to avoid long-term complications, and picking up the diagnosis at appropriate time so that appropriate intervention can be done. Having said that, a large number of children who present to us with rickets actually have what has been termed as a nutritional or a vitamin D deficiency or calcium deficiency rickets, which does not require extensive evaluation. So therefore, we need to have a balance between not doing unnecessary workup on one hand, while trying to do a reasonable workup and not missing children who have refractory rickets. We'll focus basically about the what, why and how of rickets, with particular emphasis on how to treat a child who has vitamin D deficiency rickets and when to suspect and evaluate a child with suspected refractory rickets. So if you look at this figure, we all know that all classical features of rickets are present in this child. What we are seeing is that there is a cupping, which is basically a concavity which is noted towards the distal part of the bone. And rickets, as we know, is a growth plate issue. It's a metaphyseal issue in which the growth plate apoptosis is reduced, and therefore there is increased area as far as growth plate is concerned. What we are also seeing is fraying, which is irregularity at the level of metaphysis, and splaying, which basically emphasizes that there is pressure which is coming on weak bone, which results in the lateral expansion of the bone, resulting in fraying. So these are the classical features of rickets that we see. The clinical features of rickets are dependent upon the age at which the child presents. So children who have early onset rickets will have predominant effect as far as the heads are concerned. So we'll have craniotapes and wide anterior fontanelle, wide sutures would be there. The features at a lower limb involvement will increase once the child starts walking. So we'll have more of genu valgum or genu varum, which will occur in later age groups. So now what we know is that what rickets is, why is the rickets being caused, and in this regard we all know that both calcium and phosphorus play an important role as far as bone physiology is concerned. And conventionally we have been thinking that rickets is predominantly a problem of calcium, but now we know very clearly that it's the phosphorus which plays a more important role in the pathogenesis of rickets, and phosphorus is actually responsible for growth plate apoptosis. So in this situation of phosphate deficiency, the growth plate apoptosis process is delayed, and therefore we will have larger gap between the metaphysis and the bones, and therefore the metaphyseal problem will start to occur. So it's predominantly hypophosphatemia which is responsible for metabolic bone disease in the situation of rickets. What we also need to understand is that if you have a calcium defect or a calcium deficiency because of any cause, it will trigger hyperparathyroidism, and which will again result in phosphaturia and hypophosphatemia. So conventionally, when we are thinking about whether it's a calcium or a phosphorus related rickets, ultimately it is phosphorus deficiency which is the main cause, and it happens either way. If you have a calciopenic or a phosphopenic rickets, the common end denominator is hypophosphatemia. The only condition in which you will have rickets and high phosphate is the situation of renal failure. So we all know that calcium comes from the diet, and diet also gives us enough exposure as far as aldosterone is concerned, which is then converted under sunlight to calciferol, further activated 25 hydroxyl at the liver level to 25 hydroxy vitamin D, which is the best marker of nutritional vitamin D, which is again converted at the level of kidneys to 125 dihydroxy vitamin D, which is responsible for gut absorption of calcium. Acidosis also has a direct effect as far as bones are concerned. So within the substrat, if we try to look at the causes of rickets, it can be because of dietary deficiency of both calcium, malabsorption in the setting of celiac disease, reduced sunlight exposure like disorders of pigmentation, reduced coverage of the body, increased, these will be the causes. Liver disease causes rickets more because of malabsorption, but partially because of 25-hydroxylase vitamin D deficiency, decreased conversion of 1-alpha-hydroxylase action in the setting of vitamin D dependent rickets type 1 or chronic renal failure, or finally if there is a resistance to calcitriol in the setting of vitamin D dependent rickets type 2. We can also have phosphate related problems which are associated with phosphaturia in the setting of hypophosphatemic rickets or Fanconi syndrome. Renal tubular acidosis of various forms can also cause acidosis and bone involvement. Hyperparathyroidism or pseudo-hyperparathyroidism with selective responsiveness left in the bone also presents with a metabolic bone disease picture similar to rickets. So theoretically, we can divide this whole situation into a calciopenic rickets in which the main problem is hypocalcemia, while we can also have a primary phosphopenic situation in which the main problem is phosphate deficiency. As we already alluded to, in most situations except chronic renal failure, the phosphorus levels in a child with rickets will be low. The way to distinguish between calciopenic and phosphopenic rickets is that children with calciopenic rickets typically are more symptomatic, they look sick, they have a history of hypocalcemia, tetany, predominantly upper limb involvement is there and they present at an early age. While those who have a phosphopenic problem will be otherwise fine, they will have predominantly late presentation because of that, affecting mainly the lower limbs, will never have hypocalcemia and will not have hyperparathyroidism. So these are the two distinguishing features which will really help us in terms of diagnosis of rickets. So rickets can largely be calciopenic in the setting of vitamin D related problems or renal failure. They have early onset, tetany, hypocalcemia and hyperparathyroidism. Or it could be because of acidosis in the setting of both proximal and distal RTA. And conventionally Western reports will say that distal RTA is a rare cause of rickets. But in our setting, with delayed diagnosis, distal RTA often presents with rickets and bony deformities. They would have polyuria, acidotic breathing, nephrocalcinosis and failure to thrive. And finally, we could also have a problem of phosphorus metabolism which presents as phosphopenic rickets. Traditionally, they would be associated with asymptomatic children who have lower limb involvement, normal calcium and normal PTH levels which are found in this setting. Now we know about the what and why of rickets. The next question which comes to our mind is how to go forward. So we'll come back to this case, 5-year-old boy with classical features of rickets, the X-ray of whom we had seen earlier. So which dose, which preparation and which route shall we use? And if you look at the literature, there would be a plethora of options which are available, from using injectable vitamin D to a liquid preparation of vitamin D to a STOS therapy to regular therapy and duration. It becomes a real confusion. And how do you follow up this child? So if you just go through the guidelines as far as the Endocrine Society is concerned, as far as treatment of vitamin D deficiency is concerned, in most situations, if we use a daily dose of around 1000 to 2000 international units will be suffice to treat it over a period of around 6 to 8 weeks. Situations wherein we have an issue in terms of compliance, giving a STOS dose of therapy of around 1,50,000 or 150,000 international units of vitamin D in younger children and between 3 to 600,000 international units in older children can also be used. Beyond 1 year of age, they also recommend the use of a weekly dose of approximately 50,000 units as an option as compared to the daily dose. The concerns as far as vitamin D toxicity or hypercalcemia are unfounded if you are using oral preparations and most likely occurs in the injectable setting. And injectable vitamin D should therefore be reserved for children who have malabsorption. Very important to remember that a large number of children with rickets actually have calcium deficiency, and unless and until we give them calcium, they will not respond. So all children with rickets should receive both calcium and vitamin D, particularly to respond to the situation which can happen of hungry bone syndrome, in which once we give vitamin D and the bone formation increases, all the calcium is being taken on by the bone, resulting in hypocalcemia, tetany and symptoms. What we need to understand is that once we give vitamin D, the bone formation increases and that may result in increase of alkaline phosphatase and bone pain may actually increase. So these are not indicators of inadequate response to vitamin D therapy, but should be considered probably as a possible response to therapy. The most important thing to look at in terms of response is the white line of healing, which happens typically between 3 to 6 weeks of therapy with vitamin D. So let's go through a few situations and see whether this child actually would fit into a possibility of a nutritional or a refractory rickets. So this is a 3-year-old boy with rickets, given 60,000 international units of vitamin D, complains of bone pain, alkaline phosphatase went up to 1,000 international units per liter, and calcium is normal. This is the X-ray. So do we consider this child to be having refractory rickets? No. If you really look at, there is a white line of healing which is already appearing, and this actually is a normal response, and we don't need to be worried a lot about this situation. 4-year-old girl with rickets and was given osteocalcium 5 ml BD for 30 days, and still there is no line of healing. So is this refractory rickets? No, this is not refractory rickets. This is inadequate treatment because this child has not got any vitamin D, and refractory rickets by definition is lack of response to 2 adequate doses of vitamin D, 2 adequate courses of vitamin D therapy, and this child would not fit into that. So this is inadequate treatment and not really refractory rickets from that sense. 3-month-old boy with seizures, and the calcium was very low, phosphorus was also low, rickets was also present. So do you think this could be refractory rickets? It is quite evident that if you have a very early onset hypocalcemia with rickets, we need to be worried about a possibility of vitamin D related metabolic issues which need to be worked out. Vitamin D deficiency usually causes hypocalcemia, but rickets is unusual in those situations. 5-year-old girl with rickets, and we can see that she has significant growth failure and has significant polyuria. So do you think this could be a nutritional or a refractory rickets? So if you have a child who has severe growth failure and other symptoms like polyuria, we have to think of causes beyond nutritional rickets. In this case, emphasizes on that. 14-year-old boy, and we can see looks otherwise fine, predominantly lower limb involvement, has rickets, has received tons of vitamin D, has normal growth, and this is the X-ray which showed multiple areas of involvement. Is it refractory rickets? And I think clearly if somebody has received multiple courses of vitamin D which has been adequately treated, we need to be concerned about the possibility of refractory rickets as in this situation. 12-year-old girl with multiple fractures, polyuria, myopathy, failure to thrive. Is it refractory rickets? Most definitely. Nutritional rickets should not cause pathological fractures. So if a child actually has fractures, we should think of the possibility of a refractory rickets. So the situations in which we should go beyond nutritional rickets include polyuria, failure to thrive, pathological fractures, and hypocalcemia. So how do we approach a child who has low vitamin D levels? If the child presents to us with hypocalcemia, we should give a course of activated vitamin D and calcium. And once the calcium becomes normal, vitamin D on a regular basis and calcium should be given to maintain the levels. In children who have rickets, we should think of a possibility of refractory rickets in the form of polyuria, seizures, fractures, and growth failure. If these things are not present, we can give either a daily course of vitamin D or give a weekly therapy of 50,000 international units per week for 6 to 8 weeks for children beyond 1 year of age. If there is a response, we should look at X-ray, and in 6 weeks we do see a line of healing, we continue vitamin D and calcium and for a period of time. If there is no response, we should think of a possibility of refractory rickets. On the rare possibility of a child with low vitamin D having no rickets or normal alkaline phosphatase, we should start with vitamin D and repeat the levels after 6 weeks and try to maintain that in that regards. So now we'll go forward in terms of evaluation and situations. The most important things to consider as far as the refractory rickets are concerned are renal failure, distal tubular acidosis, hypophosphatemic rickets, and vitamin D dependent rickets type 1 and type 2 necessarily in that order. So the key things to look at in a child with refractory rickets include the calcium, phosphorus and alkaline phosphatase. Hypocalcemia in this setting is indicative of a calciopenic form of rickets and excludes hypophosphatemic rickets entirely. All children with rickets will have low phosphorus levels, and high phosphorus levels should be a direct pointer towards renal failure or rarely a possibility of pseudohypoparathyroidism. Similarly, alkaline phosphatase levels are high in most children with the exception of hypophosphatasia, which is a defect in alkaline phosphatase synthesis, or a possibility of renal tubular acidosis in which the levels are reasonably normal. Creatinine levels are absolutely essential to exclude renal failure, which is the number one cause of refractory rickets in children. PTH again helps in distinguishing between the hypophosphatemic rickets from vitamin D dependent rickets in situations wherein the phosphorus levels are low or normal and calcium levels are normal, with high PTH indicative of VDDR type 1 or type 2. Blood gas should be done in children who have normal and low phosphate along with polyuria, acidotic breathing and failure to thrive suggestive of renal tubular acidosis. So this is a busy slide which shows about the various investigations that can be done and which should be evaluated in that regards. The key points to remember here is that phosphorus levels if high are indicative of renal failure. Urinary calcium levels and PTH levels are usually high, but they can be normal in the setting of hypophosphatemic rickets or renal tubular acidosis, while urinary calcium is high in the setting of distal RTA. So how to approach a child with refractory rickets? Look at the phosphorus levels. If the phosphorus levels are high, look at creatinine. If creatinine is normal, it's most likely pseudohypoparathyroidism. Normal phosphate should prompt to evaluation of blood gas. If the blood gas shows RTA, it will be acidosis will be quite evident. If it's normal, look at calcium, with hypocalcemia indicating vitamin D dependent rickets. While if the calcium levels are normal and the PTH levels are normal, look at hypophosphatemic rickets, or if you have hyperparathyroidism, it suggests your vitamin D dependent rickets. So just by using a phosphorus, a creatinine, blood gas and a PTH, we can really classify broadly in terms of the cause and etiology of refractory rickets in most cases. So let's go back to the cases that we were discussing and see what could be the possible cause. So this is a 3-month-old boy with seizures, hypocalcemic rickets. Its early onset is there, most likely vitamin D dependent rickets, especially when the vitamin D levels were normal. 5-year-old girl with rickets, very short and failure to thrive. The first possibility would be a renal rickets. Look at creatinine and it was found to be high. So this was a chronic kidney disease situation. 14-year-old boy with predominantly lower limb involvement, multiple things, otherwise fine and growth normal. Most likely this is hypophosphatemic rickets. Very low level of phosphorus and PTH is normal. 12-year-old girls with multiple fractures, polyuria, myopathy and failure to thrive. This is a classical presentation of distal renal tubular acidosis, has significant acidosis and renal calculi. What we need to also remember that every child who has bony deformity is not rickets, and possibilities of fluorosis, pseudohypoparathyroidism, hypophosphatasia and skeletal dysplasia should be considered. And this is a classical example of a child who had refractory rickets, had hypocalcemia, hyperphosphatemia and normal renal function, high PTH, confirming the diagnosis of pseudohypoparathyroidism. We should also be aware that giving too much treatment can be a major problem. So this was a 2-year-old boy with rickets who was given 3 injections of erythritol, presented with irritability and polyuria, hypercalcemia and high levels of vitamin D, had to be treated with hydration, furosemide and steroids. Thus, while vitamin D deficiency is quite common, and most situations there is a wide therapeutic window as far as treatment is concerned, giving injectable vitamin D can have adverse effects as far as hypercalcemia and other symptoms are concerned. So the key points to remember in a child who has rickets is that we should always give a trial of calcium and vitamin D before doing extensive workup, but still keep an eye on the pointers of refractory rickets. So if you have a child who has very early onset rickets, has fractures, hypocalcemia, or has severe failure to thrive, think of a possibility of refractory rickets. Phosphorus is the most important investigation, with high phosphorus indicating renal failure. And don't give multiple doses of vitamin D if a child is not responding to 2 courses. One needs to evaluate for the possibility of refractory rickets.